from Medicine 2. She'll be presenting on scarred beauty.
Good morning, everyone. I'll be presenting about scar beauty on behalf of Medicine 2. Coming to the case scenario, Mrs. Yam, she is a 24-year-old lady from West Bengal, presented with complaints of thickening of skin since 2 years and weakness of all 4 limbs since 2 years and breathlessness on exertion since 2 months. Coming to the history of presenting illness, she was apparently normal until 2 years back when she developed thickening of skin initially in the hands, followed by the legs, and then she noted she also developed in the face, neck, which was insidious in onset, slowly progressive. For the last 6 months, she also noticed that it is associated with difficulty in opening the mouth. She also had history of Raynaud's phenomenon present since 2 years on cold exposure also. And for the past 2 years, she has progressive weakness of all 4 limbs. Initially started with climbing stairs and getting up from the bed from sitting to standing position. And then she developed difficulty in lifting objects overhead. She also required the support of her hands against her legs to lift her neck from the bed for the past 6 months. There is no history of diurnal variation of the weakness. And there was also a history of chronic exertional breathlessness after climbing 1 feet of stairs for the past 6 months. There was no other significant history, and past history also not nil significant. On examination, her vitals were all normal. General examination, she had infraorbital hyperpigmented rash, and sclerodactyly was noted in the fingers, and she also had skin thickening in the fish, and she had salt and pepper skin rash in the neck, trunk, hands, and feet. Mouth opening was restricted to 2 fingers. She did not have any digital pits. So on the systemic examination, CNS examination, her higher mental function was normal and there were no cranial nerve deficit. Motor system examination, she had mainly proximal muscle weakness, bilaterally involved, symmetrically present, and neck flexion was also weak, but her single breath count was normal and she did not have any sensory involvement or other deficits. Other system examination was normal. So coming to the syndrome complex, she's a 24-year-old lady with skin thickening, Raynaud's phenomenon, and proximal muscle weakness without sensory, bowel, and bladder involvement. So our differential considered was systemic sclerosis or mixed connective tissue disorder, scleroderma-myositis overlap, or paraneoplastic cause for the systemic sclerosis. So coming to the investigations, her hemoglobin at presentation was 11 with a WBC count of 9,300, platelets of 2,47,000. Her creatinine was normal. Her LFT showed elevated liver enzymes, otherwise normal. Thyroid was also normal. For the autoimmune workup, her ANA was come as 2+ speckled. Otherwise, all the workup for systemic sclerosis actually come as negative. SSA, SSB, SCL70, dsDNA, UNRNP, CRP, everything was negative. Her myositis profile in view of the proximal muscle weakness was also negative. However, her CPK was 4,517. So we went ahead with anyway, clinically she's diagnosed her systemic sclerosis. We went ahead and did the other organ involvement workup. Her DCT has come as negative. Her 24-hour urine protein did not have any proteinuria. Echo to rule out pulmonary hypertension was actually normal. Spirometry showed a restrictive pattern. CT thorax and abdomen was done. One to look for the features of ILD and second to rule out the paraneoplastic cause for lymphadenopathy. So CT thorax showed NSIP pattern of ILD with dilated esophagus suggestive of esophageal dysmotility. EMG showed a myopathic process. And nail fold capillaroscopy showed dilated tortuous capillaries. So with all the features, she was diagnosed to have systemic sclerosis with myositis with ILD. So I'll be talking about 3 points about systemic sclerosis, cutaneous manifestations, and the myopathy in the scleroderma. So coming to the introduction, systemic sclerosis is a connective tissue disorder which is mainly associated with the fibrosis and the vascular endothelial injury. These two are the main reason for all the manifestations in the systemic sclerosis. The incidence noted is 18 to 20 per million population per year. Onset is usually 35 to 50 years of age. With the it's a female is to male ratio. It's a 7:1. So coming to the scleroderma per se, we have actually 2 types, systemic sclerosis as well as localized scleroderma. In the systemic sclerosis, we have limited as well as diffuse and scleroderma, sign scleroderma. In the localized, we have morphia as well as linear scleroderma. So our patient is not localized. She had in the face, legs and hands, and also salt and pepper rash was there. So she's coming to the spectrum of systemic sclerosis limited, which I'll explain later. So coming to the antibodies associated with the systemic sclerosis. So each of the antibodies is usually have special organ involvement. So main thing is SCL70, which usually has pulmonary fibrosis and cardiac involvement, and centromere antibody with PAH, calcinosis, and severe digital ischemia. Other thing commonly we check is the UNRNP, which is associated with overlap with like SLE, inflammatory arthritis, and pulmonary fibrosis. She did not have any of this antibodies. However, she for the classification criteria of systemic sclerosis, she actually fulfilled the criteria. She had proximal scleroderma with skin thickening. She did not have any fingertip lesion. She did not have any telangiectasia. She had abnormal nail fold capillaries. She did not have any pulmonary hypertension, but had interstitial lung disease. She had Raynaud's phenomenon. And her antibodies are all negative. With the clinical features itself, her score goes more than 9. Score more than 9 is suggestive of systemic sclerosis. So this is ACR Euler criteria 2013. There is another criteria used is given in the Kelly's textbook of rheumatology, where they have used the 4 or 5 features which is suggestive of scleroderma. One is the ACR criteria, which has only 4 features: proximal scleroderma, digital pitch, sclerodactyly, and pulmonary fibrosis. So our patient had sclerodactyly, pulmonary fibrosis as per ILD, and proximal systemic sclerosis features. And the CREST criteria also, she fulfilled Raynaud's phenomenon. She didn't, and esophageal dysmotility and sclerodactyly. With this clinical feature itself and pulmonary fibrosis, she was diagnosed to have systemic sclerosis. So this is how we diagnosed. She had clinical features of scleroderma. Autoimmune workup was, however, negative. Other organ involvement, she had ILD. So our patient satisfied ACR Euler criteria and ACR criteria and the CREST criteria. So coming to the cutaneous features of the systemic sclerosis, it actually comes in 3 phases: edematous phase, atrophic phase, and indurative phase. So initially it starts with edema followed by atrophy and the indurative phase. I'll tell what our patient had. So this is the table given in Harrison, where they've given the involvement, organ involvement, as well as the percentage of organ involvement in the limited as well as diffuse systemic sclerosis features. So how we tell it's a limited cutaneous involvement or the diffuse cutaneous involvement is, usually in the limited, it is limited to fingers distal to elbows, face, and has a slow progression, whereas in the diffuse, it involves the trunk and has rapid progression, which what our patient had was a limited cutaneous scleroderma. And Raynaud's phenomenon can be present in both. Musculoskeletal involvement also is more severe in diffuse. ILD is also present in both of them. So our patient had skin involvement suggestive of limited. Raynaud's phenomenon was present, and she had interstitial lung disease. Other things she did not have. So this was taken after consent. This is the old picture 2 years prior to developing the disease. This is after 2 years at the current presentation. So we can notice that she has lost significant amount of weight, and we can see that her face has become low and she has pinched nose. Her mouth has become downturned. And this is a salt and pepper rash which our patient had. And here we can see the skin thickening in the interphalangeal joints. So how we assess the skin thickening is the modified Rodin score, which they have checked with the pinching whether the wrinkling is present or not. With that, they'll be able to classify into grade 4. So this is about the cutaneous part, and the muscle involvement is usually present as myopathy or myositis. So myopathy is common 14 to 96%. Myositis is present only in 10 to 15%, usually in association with overlap syndrome or MCTD. So antibody PMSCL is usually strong association with overlap, which our patient did not have, and is also associated with cardiac and pulmonary involvement. Another thing is the myopathy in systemic sclerosis. They have mentioned that it is associated with more mortality compared with the systemic sclerosis patient without myopathy. So treatment wise, Raynaud's phenomenon vasodilators, as we all know, for our patient, because she had the muscle involvement and the ILD, she was started on prednisolone 1 mg per kg and MMF in view of ILD. The 2 things I wanted to focus on. One thing, even if the antibodies are negative, clinical features suggestive of systemic sclerosis, we can still go ahead and diagnose as per ACR Euler criteria, and the cutaneous manifestations staging I wanted to inform, and myopathy scleroderma overlap I wanted to inform. Thank you.
Thank you, Dr. Brightlin. Let's give Dr. Brightlin a hand. Are there any malignancies that we must look out for in the future?
Sir, if it's a myositis scleroderma overlap, initially if there is a dermatomyositis 2 years or 1 year down the line, they are prone to develop malignancy. So they are supposed to come for follow-up every 6 months to 1 month with the repeat CT, neck, thorax, and
So
abdomen.
what malignancies do you look for?
Usually this small cell lung carcinoma, lymphoproliferative is not usually associated with it.
Okay.